will see, it is quite different from what we've heard up until now. This is a population-based study. The study that I'm presenting today is part of a larger effort to understand the application of genomic technologies in the prenatal setting. And today I will share with you our findings that are related to adult onset conditions in pregnancy. So just to start, a quick reminder, karyotype has been the major method of prenatal diagnosis for over 50 years. It has been entirely replaced in Israel by the chromosomal microarray analysis, CMA, since 2019, that is aimed to target submicroscopic deletions or insertions in the fetus done by amniocentesis or CVS. And we see more and more individuals, women that undergo whole exome sequencing in pregnancy, mainly in complicated pregnancy. However, we see more women also choosing to perform whole exome sequencing even in uneventful pregnancies. It is quite obvious that whole genome sequencing, as well as non-invasive testing, is probably just around the corner, and it would be used for prenatal diagnosis in the near future, making most women a target for testing. The advanced genomic technologies that I'm going to focus on today are mainly these ones that I'm highlighting here, but actually we are more focused on the CMA testing, as this is the current method being applied, but generally we'll see that these are more theoretical questions and are related to any advanced genomic technology. So obviously they have their benefits. They have the increased capacity to detect childhood onset pathogenic findings, which are the target of prenatal testing. But in parallel, they also increase the likelihood of identifying other types of findings. These would be findings, CNVs, copy number variants of uncertain clinical significance. I will not discuss these today. And generally, we expect that their proportion will get smaller as more information is being accumulated and interpretation becomes better with time. Susceptibility loci, another type of potential finding, are recurrent CNVs that are associated with increased risks for neurodevelopmental and psychiatric conditions, and they're characterized by incomplete penetrance and variable expressivity. And the major focus of the talk today would be the CNVs with increased risk for adult onset conditions. Again, these three types of findings are considered incidental findings that could be potentially identified when women undergo prenatal testing using these technologies. So if we talk a little bit about disclosing risks for actionable adult onset conditions in pregnancy, let's first mention actionability. And it is defined by the American College of Medical Genetics by taking into consideration the severity, the penetrance, and the impact of available treatment. And most professional guidelines, in fact, support disclosure of high penetrant adult onset actionable conditions that are identified in pregnancy due to these considerations that I've mentioned. In whole exome sequencing, ACMG has actually identified a set of genes that are associated with actionable conditions that merit disclosure, mainly associated with cancer. But when we talk about the application of CMA in prenatal testing, there are specific challenges. So the first one is that, as opposed to the whole exome sequencing that is commonly done in the setting of trios, the fetus, the mother and father, in order to enable the interpretation of the findings, CMA is usually performed in the fetus only, And only if a finding is detected, then the parents get tested as well to facilitate interpretation of the finding. So in that case, when a fetus is being identified as having some a variant of adult onset related to adult onset conditions, this identification enables to identify the parents and the family members that are at risk and provide them with information that could potentially be life-saving. And this is indeed the benefit. However, we should remember that this undermines the traditional purpose of prenatal testing, as it is focused or supposed to be focused on the current health status of the fetus and the newborn, usually. And it raises actually dilemmas that are related to predictive genetic testing in adults. In addition, in CMA, because of its characteristics and the way the methodology is built, the application, it's actually impossible to predetermine a set of genes. CMVs may encompass a large set of genes, and what happens in real life is that these decisions are left to the labs and to the clinicians, whether to disclose the information or not to. And the last challenge is that actionability could be actually perceived differently by various people. And some would say that having information on the fetus, even if it's adult onset and it is non-treatable, it is still information that they would like to receive in order to plan ahead or to consider what they do with the pregnancy. What do we know about parents' attitudes towards receiving genomic information on the fetus? So there are several studies that show that women generally are more likely to request extended information on fetus that is beyond the clearly pathogenic childhood conditions which the prenatal testing is being done for. In the setting of adult onset conditions, there is very limited data, empirical data. Two of the studies that have been published are actually ours, and they do offer support for the women's and parents' wish to receive information on adult onset diseases in their offspring. In terms of characteristics of women who choose or do not choose to receive this information, this is unknown. And therefore, we were set out to explore these objectives. The first is to examine the women's attitudes towards receiving different types of genetic information in pregnancy. As I mentioned, it's part of a larger study, so we had different types of genetic information, and I would focus primarily here on the adult onset conditions, but will also mention some preliminary data we have on the SLs related to autism spectrum disorders. And we also wanted to see what are the characteristics of women that are associated with their choices. So I would start with describing our participants in data collection. These were women that were hospitalized right after delivery in maternity wards of very large tertiary medical centers in Israel. They are geographically and social-culturally diverse in terms of the population they serve. These women were from all ethnicities, giving birth between May 2017 and April 2019. And they all gave birth to healthy newborn and were approached by our research assistant asking, offering them to participate in the study. Consenting women were then anonymously interviewed using a questionnaire that we have developed for this study. So we, in the questionnaire, actually wanted to collect information on 5 major components. The first one is the primary outcome, the primary dependent variable, which is the women's willingness to receive genetic information on different types of genetic conditions. Here I present the severe congenital diseases, actionable adult onset conditions, and non-actionable adult onset conditions. These women were given some kind of a scenario, and our interviewer was asking about severe congenital diseases leading to death in childhood, about actionable adult onset conditions using breast cancer as the example, and in non-actionable adult onset conditions using Alzheimer's disease as the example. And women were requested to rate their agreement with receiving or disclosing this type of information from strongly agree to strongly disagree, a 5-level Likert scale. The other information we collected using this questionnaire was reasons for and against disclosure of information on adult onset conditions in pregnancy. And then the primary independent variable, explanatory variables were socioeconomic variables, what we call the socioeconomic domain, obstetric and medical characteristic of the women, and information related to the women's psychological well-being. We validated this questionnaire using a retest in women who recently gave birth and expected the data for internal consistency. We use the 5-level Likert scale that I've described in a dichotomized manner in order to reflect agreement versus disagreement with interest in disclosing the information. And we use multivariable logistic regression models in order to assess the independent associations of every variable part of the 3 domains with our outcomes of interest, which are the conditions, the genetic conditions. So I'm going to show you some of our results. First of all, we were able to interview 941 women with a total of 77% response rate, which is quite high. And for selected characteristics that I'm showing you now, we were able to obtain a very nice distribution on various characteristics. Here, I present the sociodemographic. You can see here the religious affiliation or the degree of religiosity was actually a strong aspect of our study. The secular population was around a quarter, and the Orthodox and ultra-Orthodox population in Israel, mainly Jewish women, are very highly represented in our sample due to the high reproduction rate in this population. So this is actually not surprising, yet very unique in the sense that women from these populations are not inclined to participate in genetic studies. So we were able to obtain a very interesting and unusual sample. We have women with and without academic degrees. Focusing now on the psychological characteristics, we obtain information both on the level of concern of the health status that we asked women to self-report. We see again a variation in the level, and we use the validated Kessler 6-item scale, which measures psychological distress on a population level. It's a quite common screening tool. And we can see that, as expected, we have a small proportion of women who are clinically distressed, and we do have a substantial proportion that are moderately distressed, and we combine the 2 groups together for the analyses. So let's look a bit on the data. So the first thing I would like to show you here is actually the levels of agreement with disclosure for the various types of genetic information in pregnancy. As you can see here, I'm presenting results for the 3 different conditions of interest And these would be the severe congenital diseases, the actionable adult onset conditions, and the non-actionable conditions. We actually chose to use the severe congenital diseases here as sort of a comparison. And we indeed see that women's agreement with disclosure for the severe congenital diseases was the highest, over 70%. It got a bit lower when asked about the actionable adult onset conditions, and it got lowest when it was the non-actionable adult onset conditions. What we can see here that women are, their decisions are naturally affected by the severity of the disease and by the treatability. When we look here on decisions with respect to all the combinations of all three conditions, we see very interestingly that there are about 30% of women that would like to receive information on all three types of conditions, and there are almost 20% of women that do not want to receive any information. However, interestingly enough, we have about 50% of women that actually choose various combinations in terms of what they'd like to know. So this indicates that women do not just automatically check the boxes. They really think through these complex concepts and make a decision based on that. Here are results of the multivariable analysis. As I said before, these are logistic regression models where we simultaneously adjust for variables from all three domains. I show you here only the variables that were found to be statistically significant. However, these estimates that I provide here are adjusted for the rest. I'll walk you through this slightly busy slide. So what we see here in this column is the outcome of interest is the actionable adult onset conditions. And what we see, for example, here with religious affiliation is that compared to the secular women, the ultra-Orthodox women are less inclined to be interested in disclosure of adult onset conditions. And this is reflected by the odds ratio that is lower than 1 and obviously statistically significant. In terms of the psychological domain, we have also an interesting finding that is related to the actionable adult onset conditions. We can see that women who are concerned for the health of their fetus compared to the ones that reported not being concerned are actually more interested in receiving this type of information. The most interested are the ones that are actually very concerned. And this is opposed to the women that are clinically distressed by the Kessler 6 scale, again, combining moderate and severe stress together. And these women are actually less inclined. So we see here an interesting phenomenon where concern leads to information seeking, while distress or clinical distress leads to information avoidance. Here, I would like to show the results for, for the non-actionable and the severe congenital diseases in a similar way. What is important for me to emphasize here is if we look now at the ultra-Orthodox population, and we saw that they're less inclined to get information on actionable adult onset conditions compared to the secular population, moving in this row to the non-actionable adult onset conditions or the severe congenital diseases, we see that they're even more objective to get this information. So the difference between the ultra-Orthodox and the secular population is actually lower for the actionable adult onset conditions, meaning that there may be some interest in receiving this information. And here in this figure, I would like to mention a few words about that again. So if we look here at the different religiosity levels, secular, traditional, and Orthodox, we see a very similar trend in the interest in receiving information on the three different types of conditions. Severe here in dark gray, actionable adult onset in the middle bar, and the non-actionable in the right bar. And we see that for all of these three religiosity groups, there's a clear trend of decreasing interests. What we see, however, in the ultra-Orthodox population is actually that the most interest is actually in the adult onset actionable conditions, meaning that these different groups of women actually have different motivations for receiving information. And whereas in the ultra-Orthodox population, the termination of pregnancy is less of an option, they might actually not want to receive information on severe congenital diseases at all, but do understand that knowing that the fetus has a variant that reflects an actionable condition in the family could be helpful for their health and the health of their family members. In terms of the reasons, so very briefly, I would mention that both for the actionable adult onset conditions and the non-actionable adult onset conditions, women, both those that are in favor of disclosure and those that are against disclosure, did not rate considering pregnancy termination as a substantial reason for receiving or wanting to receive this information. It was very low for the actionable adult onset conditions. It was slightly higher, but still quite low for the non-actionable adult onset conditions. So we could say that the motivation of pregnancy termination is not really there. And it is important because some objectors for the disclosing of adult onset information on fetus argue that it would lead to increased pregnancy termination. So to summarize the findings, we see that women are able to distinguish between nuanced and complex types of genetic information. This is extremely important due to the ongoing discussion between clinicians if choice should be given and if women are able to actually grasp this genetic information. Most women support disclosure of actionable adult onset conditions, and as we saw before, a lower level of religiosity and greater concern for fetal health and lower personal distress were associated with greater interests. We saw that within the ultra-Orthodox population, quite surprisingly, 45% of women did show interest in receiving this type of information. And as I said before, there was little support for termination of pregnancy based on increased risk for adult onset conditions. So strengths and limitation, this is a large sample of women that are likely representative of Israeli women giving birth. We do believe that although Israel is unique and has its own characteristics, the socio-demographic, cultural, and religious diversity could add to the accumulated work focusing on underserved ethnic minoritized groups and make these findings even relevant to other countries where these populations and different populations by culture, by religion are present. We do acknowledge that women's theoretical responses may not accurately reflect what their choices might have been if it was a real choice to be made, but we did not ask women during pregnancy for ethical considerations, and we still think that these women are, given that they just gave birth, had to deal with questions like that during pregnancy, and therefore their opinions are very relevant. And lastly, that we know that giving birth to a healthy baby may have immediate effects on mood or the psychological state. What are our recommendations? As we understand, the most of the decisions what to disclose is really in the clinician's hands as it is currently handled. And therefore, we do believe that clinicians should discuss prior to testing the implications of these complex findings on the health of the child and the parents. We strongly support pre-test parental choice in order to accommodate women's and parents' cultural background and their beliefs, and to allow for a culturally competent genetic counseling. We do also believe that in countries where full disclosure is practiced, clinicians should be aware of the emotional state of women and should refer women, if necessary, to mental health care providers during pregnancy. I would now very briefly also share with you some preliminary findings that are related to susceptibility loci, which, as I mentioned before, there are recurrent CNVs that are associated with increased risks. Here we chose autism spectrum disorder as an example to illustrate to the women. When we asked women in general, in a similar way that we've asked about the adult onset conditions, whether they would like to get information on autism spectrum disorders on their fetus, we could see here that around 70% actually supported that disclosure, similar to what we've seen with when asking about congenital childhood diseases. However, when we asked it a bit differently and provided some different scenarios where the ASD, actually the risks are different in different levels. So basically from 10% risk for ASD in the fetus to 40% risk for the fetus to have ASD, we see that the levels of agreement are dropping and that more women are actually have no opinion, meaning that they have a hard time deciding. And that is really interesting because this is for the first time showing that the penetrance level or the risk level does affect the decisions that women made. Here we could also see that although 40% of women support the disclosure no matter what the level was, and 22% do not or object the disclosure at any level, we do see that there's these two groups that are very interesting, and these are individuals or women that would change their mind based on the risk. So these are women that would change their mind or change their mind. They do not want to get this information up to 40%, but if the risk for the fetus is over 40%, they would like to get this information. And here we see just a lower cutoff of 20%. So to conclude this part, the preliminary part, women also grasp probabilistic information on fetus, which is not exactly trivial to actually perceive risk levels. And again, this we saw that the level of penetrance definitely influences their interest in receiving information on the susceptibility loci, similar to what we saw before, that the severity of the disease and the treatability of disease affects their choices. This preliminary data further support our recommendation to provide women and parents a choice about disclosure of complex genomic findings as they are able to perceive them and they are able to make decisions that are suitable for their backgrounds. And we do suggest to stratify the choices also by the level of risk, because we see this could have an effect on their choices. I would like to acknowledge my research team, Vitalia Liebman, who is the PhD candidate that led this work that I'm describing here, my colleagues at the Brown School of Public Health at the Hebrew University, the Department of Genetics at Hadassah Medical Centers, the many people that have contributed to this work and the funding that we've received. So thank you very much. I'll be happy to take questions if you have any.
Thank you, Dr. Hagit, for a wonderful presentation.
Thank you.
Any questions for Dr. Hagit?
I see that there's a question in the chat. If it's okay, I could respond.
Yes, you can respond to it.
Okay, so Natasha is asking me about changes to practice you have made based on your findings. So thank you for this question. Yes, we have. So at the Hadassah Medical Center, we've actually used an approach of allowing women to make a choice. So pathogenic, obviously women coming to do prenatal screening would automatically get results of a pathogenic finding, but they are offered a choice relevant to the variants of unknown significance, to susceptibility loci that are lower than 10%. And they could choose to opt out. So basically they automatically get this result unless they opt out from receiving information on adult onset diseases. So this has been applied in Hadassah for already about 3 years or so. But in Israel also, the Genetic Association also has consent forms for women undergoing prenatal testing where this choice is also being offered. But again, every institution sort of applies their own approach, but generally there is a consensus among professionals that choice should be considered. Thank you.
Any further questions? Okay, thank you so much, Dr. Hagit.
Thank you very much.
The next presentation will be by Dr. Nitika Sharma from India.